Good evening, everyone. You are all welcome to the last section of gastrointestinal anatomy, where today we will be discussing anatomy of the rectum and the anal canal. The anatomy of the rectum is very important to every surgeon, and we took it separately from the colon because of certain peculiarities of the rectum, and the treatment for pathologies, both benign and malignant pathologies, differ in both the colon and the rectum, as well as the anal canal also has a different anatomy with some peculiar features. So, and generally we know the function of the rectum is to serve as a temporal reservoir for feces, and also it has role in maintaining defecation reflex, while the anal canal also has an important role for defecation and also the continence mechanism of any individual. We are going to start by describing the rectum. Okay. The rectum is the most distal portion of the large intestine and is about 5 inches, 12 centimeters in length. And it is very important for you to mention the length of the rectum, because in describing pathologies, we normally describe both pathologies with relation to its treatment with respect to the 3 parts. Hypothetically, we divide the rectum into upper third, middle third, and lower third, so that when you are describing a pathology in the rectum, it will determine the form of treatment that will be provided. So the length of the rectum is about 12 to 15 centimeters. So when you are describing a lesion and you say it is located maybe 10 centimeters from the anal vag, the treatment will vary, especially if it's a malignant lesion, from a lesion that is within 6 to 10 centimeters from the anal vag, and from that is less than 6 centimeters from the anal vag. Okay? Now, what is the extent of the rectum? The rectum commences in front of the third sacral segment, and it ends at the level of the apex of the prostate or lower quarter of the vagina, where it leads into the anal canal. So what is the extent? In front of S3 segment. This is the S3 segment. That is where the rectum commences. And it ends in front of the apex of the prostate in males, or the lower quarter of the vagina in females. If this is the vagina from here to here, and you divide it into 4 segments. Now, the extent of the rectum in females ends in the lower 1/4 of the vagina. Now, the course of this rectum is marked by 2 major flexures. There are 2 major flexures marking the course of the rectum. The first one, the sacral flexure, taking the concavity of the distal sacrum. This, okay? And the anorectal flexure, having convexity anteriorly. So the sacral flexure, the rectum fall into this concave course of the sacrum, having a concavity anteriorly, while for the anorectal flexure, it has convexity anteriorly. Sacral flexure, anterior-posterior curve with concavity anteriorly. It follows the curve of the sacrum and the coccyx. The anorectal flexure, anterior-posterior curve with convexity anteriorly. This flexure is formed by the tone of the puborectalis muscle, and it contributes significantly toward fecal continence. So it is very important for you to note that not only the internal and external sphincters maintain continence of an individual. The puborectalis at the anorectal junction, which we will see later, it also contributes to sphincter mechanism of an individual. So this is the anterior-posterior curvature and curves of the rectum. You should also understand that this rectum has some lateral flexures. What are these lateral flexures of the rectum? Now, it has three inflections: superior, intermediate, and inferior. Okay? Now, if you look at this diagram, this is the rectosigmoid junction at this point. Now, there are inflections. There is one here on the left side. There is another one on the right side. And the lower end, you have another inflection. And these inflections, they are called valves of Hostings. They give the rectum an appearance of a lazy E. Okay? As if you have an E sign like this. Okay? And this lazy E is formed by three inflections that are called valve of Hostings. As simple as this, you can be asked in your MCQs that you have two valve of Hostings and two left and one right, giving the rectum its shape. So you have to be very careful. You have two left, 1 and 2. Then you have one right, giving the lateral flexion of the rectum, the lazy E shape. Now, if you look at this structure of the rectum, below this valve of Hostin, you have a dilated portion of this rectum that is called the ampulla. Okay, this portion is called the ampulla that forms a temporal reservoir for feces. And it is at that ampulla that the defecation reflex is stimulated. Okay, when there is accumulation of feces in that ampulla, it stimulates the defecation reflex, and one evacuates the content of the rectum. And you should know, by the way, that's why tumors that are in the lower portion of the rectum, within this rectal ampulla, have what is called tenesmus. They will constantly stimulate the defecation reflex. Patient will have persistent urge to defecate that is not fruitful, because patient keeps on going to defecate, but they won't be passing anything but little mucus or nothing. Okay, that's why when you are taking history in a patient, and anytime you mention tenesmus, it means you have localized that tumor to the rectum. It's not a colonic tumor. When you say tenesmus, you have localized the tumor to the rectum. Okay, so we said it has three inflections: the superior, which we saw, okay, the intermediate, and the inferior, giving it a lazy E shape. These inflections are due to the valves of Houston's, which are formed by transverse folds of the internal rectal wall, projecting left, right, left. Okay, you can see how many left? You have two left, left, right, left. Don't forget this. Okay, so you can see the shape of the rectum is determined by those sacral flexure and rectal flexure, as well as the inflections caused by the valve of Houston's. Now, the final segment of the rectum, as we said, the ampulla, relaxes to accumulate and temporarily store feces until defecation occurs. It is continuous with the anal canal, which passes through the pelvic floor to end as the anus. Okay? Now, let us see the peritoneal coverings of the rectum. Now, you should know not the entire length of the rectum is covered by peritoneum. The upper part, middle, and the distal third has varying degree of coverage of this peritoneum. So, in the superior third of the rectum, the anterior surface and the lateral sides are covered by peritoneum. So in the upper third, you should know it's just anterior and lateral. The posterior is not covered by peritoneum. In the middle third of the rectum, okay, only the anterior has peritoneal covering, because from the middle third, it now reflects anteriorly, leaving the lower third completely extra peritoneal. Okay, because from the middle third, these peritoneal reflections, it reflects anteriorly. Okay, so if you notice this yellowish, you can see how it reflects. Depending whether it is a male or female, it determines what is formed, the type of pouch that is formed there. Okay, so in males, the reflection of the peritoneum from the rectum to the posterior bladder wall forms the rectovesical pouch. In females, the peritoneum reflects to the posterior vaginum and cervix, forming the recto-uterine pouch or the pouch of Douglas. We've discussed this in our previous lectures, the peritoneum, okay? Now, what are the relations of the rectum? Now, it is important you know some certain fascias that are located in the anterior and the posterior rectum. It is very important you know that. Now, posteriorly, the rectum is related to the sacrum, as you can see, the coccyx, okay? Middle sacral artery, okay? The middle sacral artery, then separated by the Waldeas fascia. Now you can see this fascia here, posteriorly. It's called the Waldeas fascia, or the retrosacral fascia. Okay, it is called the retrosacral fascia. Now, this is very important not to forget that this posterior fascia, okay, you shouldn't confuse the name. It is the rectosacral fascia. The one behind is the Waldeas fascia, and the one in front, behind the prostate, is the one that is called the Nobilias fascia. Okay? So posteriorly, you have the sacrum, coccyx, middle sacral artery, as well as, which is separated by the Waldeas fascia. Then anteriorly, the upper two-third is covered by peritoneum, as we mentioned, and loops, coils of small intestine. Okay, both the small intestine as well as the sigmoid can fall there in the rectovesical pouch or pouch of Douglas in females. The lower one-third is related to the prostate, bladder base, seminal vesicles in males, or vaginum in females, separated by Denovilias fascia. The anterior one is called the Denovilias fascia. Now, because of these close relation, if you have tumors in the rectum, sometimes they can penetrate to involve the seminal vesicles, and patient might have, okay, hemospermia. You'll be seeing blood in their semen, or it might infiltrate the vaginum, and patient will be having, what do you call it? Passage of stool per vaginum. Sometimes it bridges to enter the bladder. Patient will have pneumaturia. They will be having gas in their urine, or fecoluria, or feces in their urine. Now, the fascia that is surrounding this is very important. Okay, maybe we shall talk about it later. Now, what is the blood supply to the rectum? The blood supply of the rectum, the superior, middle, and inferior rectal arteries supplies the rectum. If you remember, yesterday we talked about the inferior rectal artery, a branch, Yes, inferior mesenteric artery, a branch from the abdominal aorta. And we said the inferior mesenteric artery ends as the superior rectal artery that now divides, okay, into the right and left branch. So the inferior mesenteric artery ends as the superior rectal artery that divides into right and left branch. So one of the branches are what? Superior rectal artery, okay? And it is coming from what? Inferior mesenteric. Then there's the middle and the inferior rectal arteries. All these branches, this middle rectal artery is a branch of the internal iliac. Internal iliac. You remember the internal iliac in the pelvis? Then you have the inferior rectal artery, which is a branch of the internal pudendal. An internal pudendal is also a branch from the anterior branch of the internal iliac artery. So you can see this middle and inferior rectal artery, they all take their origin from the internal iliac artery, while the superior rectal artery takes its origin from the inferior mesenteric arteries. They supply the rectum and the anal canal. Okay? So, 5 arteries in all. Superior rectal artery is unpaired, unlike others. You see, it just comes from above but divides into 2 branches. And each of the branch will now anastomose with those other branches below. The superior rectal artery is a continuation of the inferior mesenteric artery. The middle rectal is a branch of the internal iliac, while the inferior rectal from the internal pudendal. All these take origin from the anterior branches, at the anterior branch of the internal iliac artery. Okay. So please take note of the blood supply of the rectum and the anal canal. This is just also depicting how the superior rectal artery divides into the left and the right branch that subsequently anastomose to the middle and the inferior rectal arteries. Now, what is the venous drainage of the rectum? Now, you should pay attention. This is a very important aspect of the vasculature because of 2 reasons. One, because it's a point of anastomosis of systemic and portal veins. That is one of the reasons. Then 2, because the eventual drainage, okay, to both systemic or portal is affected, okay? Usually it all affects where a malignant tumor is deposited. If it's located in an area that is drained by the systemic portion, it can metastasize to the lungs. If it is located in an area that is drained by the portal veins, it's metastasized to the liver. So The venous drainage of the rectum is carried out by the superior, middle, and the inferior rectal veins. Don't forget, these veins follow the arteries. The superior rectal veins drain the upper part of the rectum into the portal venous system through the inferior mesenteric vein. On the other hand, the middle and the inferior rectal veins drain the lower part of the rectum into the internal iliac vein. Okay? Of course, you know this is systemic. It moves to the systemic via the internal pudendal vein. Now, between those two different types of vein, the ones that drain to the hepatic portal system and the ones that drain to the systemic circulation, there are anastomosis which are clinically important in case of portal hypertension. If there is portal hypertension, they will form what? Hemorrhoids here at the point of anastomosis. These are points of what? Anastomosis of systemic and portal system. And when the portal venous pressure is greater than 12 millimeters of mercury, the portal pressure is raised, and you have various sites, which of course I believe you know, the various sites of portosystemic shunt. So this is one of the significance of this vein. And secondly, if you have tumors in the upper part of the rectum, which is drained by the superior mesenteric vein, they can spread to the lungs. This drains what? Portal. They can spread to the liver because, of course, it's the superior mesenteric vein that goes along with the inferior mesenteric artery. And you know, the inferior mesenteric drains into the splenic vein, and the splenic vein unites with the superior mesenteric vein behind the neck of the pancreas to form the portal vein. You can see this will just drain into the liver, while those located in the lower, middle, and lower third commonly they drain into the lungs. Now, the lymphatics of the rectum. The pararectal nodes, thence, they drain into where? The superior rectal and inferior mesenteric nodes. The lateral and medial to the sacral nodes, with the middle rectal artery to the iliac group of lymph nodes. Now, we'll talk about the anatomy of the anal canal. Now, the anal canal is the most distal portion of the GIT, and it's about 4 centimeters length, and it has 2 embryonic origins. The upper half is derived from the endoderm, while the lower half is derived from the ectoderm. And these two are demarcated by the dentate line, okay? The demarcation of the upper 2 centimeters and the lower 2 centimeters. In some texts, you see upper 2/3 and lower 1/3 is demarcated by the dentate line because they are from different embryonic origin. They have different neurovascular distribution. The dentate is also called the pectinate line, divides the anal canal into upper and lower parts, each one being supplied by completely different neurovascular structures. Okay, The mid-anal canal represent the junction between the endoderm and the ectoderm. So you can see at this point, okay, you have the dentate or pectinate line here. The lower half is lined by squamous epithelium, while the upper half is lined by columnar epithelium, squamo-columnar junction. And also you should know the color vary. The upper half is pinkish, while the lower half is darkish. The upper half of the anal canal has vertical columns of mucosa, columns of Mogagni, connected at the distal extremities by valve-like folds, valve of balls. Let's see what this is talking about. Okay, if this is the anal canal, the upper and the lower half, you have the lower 2 centimeters and the upper 2 cm, making 4 centimeters, separated by the dentate line. Now, the mucosa of these are separated by, there are some lines of, or there are some columns, some elevated ridges, about 5 to 6 on each side, making about 10 Mogagnis, column of Mogagni. They are called anal columns. So they are about 5 to 6 on each side. They form total of 10. On this side, you have 5. They are about 10 columns. These are called columns of Mogagni. And these columns are connected in their lower end by what is called anal crypts. Okay? These are called anal crypts. They connect these columns together. Okay? So this is called the anal columns of Mogagni. These are called anal crypts. So when you hear cryptitis, it is inflammation of these crypts. Now, what you need to know, these anal crypts, there are some openings, some sinuses that open to these crypts, and they are connected to anal glands. So these anal glands open. They are tiny glands. They are not as big as what I'm drawing. It's just to demonstrate. They are tiny glands that open into these anal crypts. They secrete mucus. And of course, if you remember the, what do you call it? Anorectal abscess. If you have cryptitis, you know, following inflammation, there's going to be what? Edema. Okay. For example, if you have cryptitis here and there's edema, there's blockage of this opening from swelling. The contents of these anal glands will not drain. So there will be stasis of secretion here. They will accumulate. Because of stasis, there will be bacterial proliferation. And when there is bacterial proliferation with superimposed infection, it forms an abscess. So that is the pathogenesis of anorectal abscess. And this abscess will try to track through the least area of resistance. okay? It tracks through the least area of resistance. When it gets here, it accumulates, okay? It can even rupture through the skin. It ruptures. And when it ruptures, what happens is all this content drains out, and subsequently, this opening will be free and it will form fistula in anu. That is the pathogenesis of fistula. This side that was previously blocked is opened, and it has connected through that abscess to the skin. It drains all its content, and you know granulation tissue is already formed here. So it forms fistula. So let's go back to this anatomy. You have columns of Mogagni that are connected at the level of the dentate line by the anal crypts. And at this anal crypt, the anal glands open into the anal crypt through some sinuses. And of course, these sinuses can, they can get blocked. Okay. So the upper half of the anal canal has vertical columns of mucosa, the columns of Mogagni, connected at their distal extremities by the valve-like folds called the valves of Ball. And that valves of Ball, this one, they are also called the anal crypt. So if you look at this diagram, these are the columns of Mogagni, okay? These are the anal crypts, okay? You can see how the anal glands open into these crypts. If there is obstruction, they can become what we just explained. Now, there's a mucocutaneous junction called the Hilton's line. There's a mucocutaneous junction called the Hilton's line. Now, just beneath this dentate line, you have the lower half of the anal canal. Okay, if you look at this, is the entire anal canal, the upper half and the lower half. Now, just beneath this lower half, you have a line that is the Hilton's line. It divides the lower half also into two. There's a point where you have mucocutaneous junction. That mucocutaneous junction is also called the Hilton's line. Then this outermost opening is called the anal vag. Now you should know this is the anatomical, this lower half is the anatomical anal canal, but the entire is the surgical anal canal. So you should know tumors that are located in the upper half. If you have anal cancer that is located in the anal canal above the dentate line, it is called anal canal tumor. But if you have a tumor that is in the anal canal below the dentate line, it is called anal margin tumor. Okay, so this is just a diagram representing what we just explained. You can further divide it into three parts: the upper half, the dentate or the pectinate line. Then you have the Hilton's line. This is the anal vag. So when you hear some certain centimeters from the anal vag, you are talking about this. When you hear the mucocutaneous line, you are talking about this. And when you hear the pectinate or dentate line, it is this. Now, the anal sphincters are responsible in maintaining the sphincter, the continence mechanism of an individual. And there are two types of sphincters, the internal anal sphincter and the external anal sphincter. You should know that the internal anal sphincter is continuation and thickening of the inner circular muscle of the rectum. The inner circular muscle of the rectum. And it has involuntary innervation. While the outer circular, the external anal sphincter is somatic, is voluntary. It has somatic innervation. Now you should know the distinct feature of the anorectum, the anus, the rectum, that makes them different from the large intestine, apart from some of these features. If you remember yesterday, we mentioned the three classical features of the colon, which are appendices epiploicae, tinea coli, as well as the hostrations. These three features are absent in the rectum. They are absent in the rectum and anal canal. The anal canal is surrounded by internal and external anal sphincter, which play a crucial role in maintenance of fecal continence. The internal anal sphincter surrounds the upper two-thirds of the anal canal. The internal anal sphincter surrounds the upper two-thirds of the anal canal. It is formed from the thickening of the involuntary circular smooth muscle in the bowel wall. The external anal sphincter, so if you look at this, you can see this is the internal anal sphincter. It's from the circular muscle, and you can see it covers two-thirds of the anal canal. Okay? It's only one-third that is not involved. It is not involved. The external anal sphincter, voluntary muscle that surrounds the lower two-thirds, you can see from here upward, lower two-thirds of the anal canal, and so overlaps the internal sphincter. It bends superiorly with the puborectalis muscle of the pelvic floor. Now you should know the external sphincter is voluntary and it has three parts. There's the subcutaneous part, okay? The superficial and the deep parts. Don't forget it has three parts: subcutaneous, superficial, and deep portion. Okay, at the junction of the anorectum, at the junction of the rectum of the anal canal, there is a muscular ring known as the anorectal ring. So if you remember what we said about the curvature, this curvature is caused by a ring that is called the puborectalis muscle. This puborectalis muscle keeps this shape, the anorectal flexure, in this position. And this puborectalis anorectal ring, this puborectalis muscle internal sphincter and external sphincter together maintain the continence mechanism of an individual. Okay? Now, if you are doing a digital rectal examination, you palpate this thickness here, known as the anorectal ring. It's formed by the fusion of the internal anal sphincter, external anal sphincter, puborectalis muscle, and is palpable during digital rectal examination. What is the blood supply to the anal canal? Superior part of the superior rectal, superior part from the superior rectal, while the inferior one half is from the inferior rectal. The lymphatics. The lymphatic drainage of the anal canal is very important. Why? Because you know they are derived from different embryonic origin. The part above the dentate line has a different drainage from the part below the dentate line. Lymphatic above the mucocutaneous junction drain into the internal iliac lymph nodes, while below these to the inguinal lymph node. That's why you see patients with anal cancers. They will have swelling in the groin. You will see their lymph nodes, their inguinal lymph node is also swollen involved. So when you are doing examination of the rectum for a patient with suspected anal cancer, you should also examine the groin. Now, the nerve supply also have different source because of same reason, okay? To the upper anal canal is via an autonomic plexus, which have sensation for what? Stretch reflex. The lower anal canal supplied by the somatic inferior hemorrhoidal nerves. The lower canal is therefore sensitive to pain, touch, temperature, okay? While that above is sensitive for stretching reflex. So you have lesions above the dentate line are usually painless. Lesions below the dentate line are usually painful. We've talked about some of these clinical features of the large intestine yesterday, the clinical application. Now for the large bowel, they say we do NMR to evaluate the bowel, double contrast bowel NMR, okay? You can see it's demonstrating the rostral markings, okay? And you should tell me what is the meaning of double contrast. Yesterday, I gave you assignment. So after this lecture, you tell me the assignment. When performing a right hemicolectomy, beware of injury to the right ureter and the right gonadal vessels. We talked about this yesterday. Some transverse colon cancer may mimic stomach cancer when they infiltrate the stomach. Carcinoma of the rectum is painless until the anal canal is invaded or the sacral nerves posteriorly is infiltrated. Now, it's also important you differentiate if you are taking a history of rectoanal cancers, you differentiate them from anorectal cancers. The difference here for rectoanal cancers, the symptoms start with a lump before pain. because it is when it has invaded and gone beyond the dentate line, that is when they will start having pain. So initially, there are features of lump that will give change in bowel habit, pencil-like stool, tenesmus. Later, they now start having pain. It has invaded the anal canal, and subsequently, they might have incontinence. But for here, anorectal, it starts with pain first before other symptoms. For carcinoma of the rectum, when it is proximal, when the proximal 1/3 is involved, an anterior resection is indicated. When the middle 1/3 is involved, a lower anterior resection and abdominoperineal resection of the rectum when the distal 1/3 is involved. And this is as a result of preservation of the continent mechanism of the individual. Because of the lazy E shape of the rectum, sometimes an extra 2 centimeters may be obtained after full mobilization. Okay, this may change a predetermined AP resection to a low anterior resection, because when you free that E shape, you gain some length, and instead of doing an abdominoperineal resection with a permanent colostomy, you will now do a low anterior resection. You should know during abdominoperineal resection, the dissection takes place anteriorly and posteriorly in those fascia of denovilia and Waldea, respectively. Emergency loop colostomy can only be performed in those parts of the colon that has mesentery. That is the transverse and sigmoid colon. Primary hemorrhoids are said to be disposed at 3, 7, and 11 o'clock because this of the way the superior rectal artery are branches. So that those are the sites where the primary hemorrhoids are located. Okay, they are, because of the vessels are located at 3 o'clock, 7 o'clock, and 11 o'clock. So when there is hemorrhoid at this point, they are called primary hemorrhoids. They are appearing at the primary position of the distribution of those vessels. Hemorrhoids that occur in between these sites are called secondary hemorrhoids. Non-operative treatment of hemorrhoids, like rubber band ligation, injection of sclerotherapy, can be done without anesthesia because the mucosa above the Hilton's line is supplied by the somatic nerve. It's not supplied by somatic nerve. So we've come to the end of today's lecture. So if you have any question, you can ask if there is any question. Yes, any question?
Thank you very much, sir, for the presentation. It was really educative. I don't have a question. It's just I just wanted to commend you on how you explained the pathogenesis of the fistula in ano. So there's a correlation between fistula in ano and abscess. So it's abscess that occur that forms the fistula in ano. All sorts of them are separate diseases. It's like a continuum. I didn't know that, or I didn't get the whole idea of it.
Yes,
now
it's a spectrum of the same disease. It's a spectrum of the same disease.
Okay. Thank you very much, sir.
You're welcome. Any other question, comments? You know, if you don't ask question, me, I have question because I gave you assignment yesterday. Hope you have all done my assignment.
We are very aware of the assignment.
Okay, so who is answering my assignment? Yes. Who and who have did the assignment?
There were 3 questions that were asked yesterday.
Okay,
The
Sarah
first
Chioma
one,
Ogugu is still with us. Is it Ogugwa? You are still with us today, Dr. Sarah. Yes, why, Dr. Mary, I'm sorry for interrupting. The first one is,
yes, the first question is, what are watershed areas of the colon?
okay,
Then the second one is to the critical point.
yes,
Then the third one is arc of Raylan.
yes. Go ahead.
No, I was reminding us of the questions.
Yes, just continue. Everybody will answer one. You better
Okay, let
answer
me
your own
choose.
now.
The arc of Raylan.
Which one are you answering, Dr. Mariam?
Sudeck point.
So the critical point.
Yes.
Yes,
So Sudeck critical point is a is a specific location in the arterial supply of rectosigmoid junction.
yes, continue.
Between the origin of the last sigmoid arterial branch of inferior mesenteric artery and where it forms an anastomosis with the branch of superior rectal artery. It is a single anastomosis and small, so that is why it's critical.
Yes. So what happens? What will you avoid there?
Anything that can cause ischemia and
You avoid
anything that can cause occlusion, you need to avoid occlusion of that point of anastomosis because it's small and it's single anastomosis. There are no collaterals.
Yeah, so when you do a resection and anastomosis at that point, so because it is precarious, your anastomosis might break down and patient will be leaking. Is it clear?
Yes.
So that is very important. She did her homework. Who else? Yes, Dr. Abdullahi.
Yes, sir.
Yes. There are 3 questions.
Okay. I have some idea about the watershed areas of the colon.
That means you did not do the assignment. If it's idea you want to
Okay.
share.
Actually, I saw the assignment late.
You saw it late. Okay.
Yes, I was traveling today, so I was busy with work in the morning, then we were
Okay.
traveling.
Okay, share the idea.
Okay, so there are usually collaterals that occur within the blood supply to the colon, but then there are 2 points that are vulnerable to ischemia, and these 2 points are vulnerable to ischemia because of the lack of collaterals in these points. And one of those points is actually the previous question, that is the Sudeck critical point. And then there is the splenic flexure. At the splenic flexure, there's also an area that has no collaterals, which are susceptible to ischemia. So these 2 points are actually the watershed areas of the colon. I don't know if there's another area, but these are the two I know of: the splenic flexure and then the rectosigmoid junction.
Okay,
And
that's splenic
yes,
flexure. What happens
yes,
there is the point of anastomosis between
of the
branches of what? Superior
superior
mesenteric
mesenteric
and
artery.
what? Anastomosis between what?
The superior mesenteric artery.
And
terminal branches of the superior mesenteric artery.
and what? And the inferior mesenteric artery. You remember
Yes.
the left branch of the middle colic artery? You remember?
Yes.
Yes.
So it's anastomosis with what? An ascending branch of what?
Of the inferior mesenteric artery.
Inferior mesenteric.
Which branch of the inferior mesenteric now? You have forgotten what we did yesterday.
Inferior colic.
You see, there is the left colic. It's a branch
Middle colic.
of the inferior mesenteric. You remember? You
Yes.
remember the right colic and the left colic?
Yes.
So
Yes.
that ascending branch is coming from what? The left colic artery, which is a branch of the inferior
Of the
mesenteric.
inferior mesenteric.
So it
Yes.
anastomosis with the what? Right branch. Is it the left branch of the middle colic artery? So at that point of anastomosis between superior and inferior mesenteric artery is also a water shed area. That is good. Then the next question.
Arc of Riolan.
The
Yes.
arc of Roland.
Aliu.
Mm.
Where is Dr. Aliu?
Riolan.
Okay, Aliu will pretend.
I'm around, sir.
Okay, answer the question.
Okay, the arc of Riolan is an arc that is formed by the anastomosis of two major arteries around the splenic flexure that is formed by the left branch of the middle colic artery and then the ascending branch of the of the left colic artery. So at that point of anastomosis, the arc that is formed by the two vessels is known as the arc of Riolan.
We did not understand.
Okay.
Clarify it as if
Okay.
you are 2-year-old,
That
you are
is
talking to a 2-year-old. We don't understand.
okay. Maybe I'm so the vessels that run these arteries that run within the mesentery of the
No,
transverse.
not marginal
Sir?
artery. Where is Sarah? We have Sarah answer the question. Dr. Alima, arc of Rioland. Okay. I'll still maintain my assignment since you guys did not check it.
iPhone is around.
Huh? iPhone. Who is
Yes.
iPhone? Who is iPhone? You see,
It's Dr. Aisha.
Aisha, where is my
Sadly, it's an idea that I have.
Okay. You people should go and do this assignment. I will not tell you because if you don't read, you will not get it.
They said it. I
Going to
only know
click
that
here.
it's an artery, but it's not constant. It's not a constant artery.
Yes, it's not a constant artery. What is it?
It's what? Sir, it links.
Inconstant artery.
Yes, it is an inconstant artery.
So we are going to stop here. You do your
Okay.
assignment and probably we'll continue with anatomy of the liver, spleen, and other abdominal viscera like bladder and the rest. So thank you all. Thank you very much for attending.
Thank you very much.